Well, Marvels, we're back for another episode.
We're here, we're laughing, we're looking at our topic, and we both kind of went, oh.
So
and
annoyed.
The topic is,
so annoyed.
What is evidence-based treatment? The
so
big
annoyed.
EBT. So, okay, let's unpack this a little bit for our audience who's like, why are they so upset about this? Why are they acting so annoyed about it?
So annoyed.
Isn't
but go ahead.
A good thing? Yeah. Okay, so I'll share with the audience now that I'm on the other side of it, and I'm not scared anymore. I had a teeny little weird spot on a mammogram. They did a biopsy. It's nothing. Evidence-based there. Do I want that? Is it easy? I'm trying to get my thumb in the screen here. Is it easy to take a tissue sample and look at it under a microscope and see whether it is a rapidly dividing cell, a cancer cell, or just something else, right? Evidence-based. We think about that in terms of like clinical medicine. We want that. Now, with psychology, it's not that we are not evidence-based. Let's put that out there to begin with. But what has happened in our field is, again, that wanting to ascribe to that medical model, and then it gets tied to money, more specifically insurance reimbursement. It's not that other forms of therapy besides like CBT or brief therapy aren't evidence-based. They are. It's that they want like this quick turnaround, identify a problem, which isn't always easy to do. If I have someone come into my office who wants to stop smoking cigarettes, great, really amenable to CBT. We put a plan in place. We can do the 7-session structured thing to get them to deal with the psychological component of quitting smoking. And then, by the way, we'd also address it medically, have them go to their doctor, get nicotine patches, and do it. What we've gotten a bad rap in our field and in our system of medicine is like this impatientness, and humans are a lot more complex than this one single behavior that I want to change, and I want to see evidence of it changing over less than 8 weeks, right? So it's one of the reasons why psychologists are a thing, why we get so much training, is because I can't boil down who you are and what you're presenting with into those easily discrete kinds of things, right? So there is evidence for, like, I practice what we'd call like person-centered or psychodynamic relational therapy, and there is evidence-based for this. But if you think about, like, if we're talking and I'm trying to establish a relationship with that person and get them to trust me and letting them see my humanness too, so they can really be like, oh, this isn't just a one-way gate, I can trust Dana. That's going to take some time. And if you think about, how do I measure that? It's a little more oogie to measure. So there have been studies that have looked at, like, this is really interesting. It drives me crazy every time I see commercials on TV for antidepressants, especially the one where it's the added one, where they're like, if your antidepressant isn't working, you can add Abilify and you can see if you get. And what I want to say is, oh, this is when I want you to go into the evidence base, because the evidence base says that therapy alone, having a relationship with a therapist and trusting that therapist, does more to alleviate depression than medication does alone for most depressions. But they don't know, they don't know that. The general public doesn't know that. For a lot of depressions, both together work the best. But there's been all this evidence of trusting somebody is like 78% of the battle, right? So it takes a while we can measure, do you trust this person? But those others, you've got a bug flying around now. Those other variables are harder to measure, those relationship variables. And if we're talking about, unpacking your recent diagnosis of being autistic and what does it mean, you don't really know who you are because everything you've done your whole life has been masking and try to please other people. And you're coming in with this existential angst of, who am I really? That's not an 8-session thing. And that's not I'm going to have you snap your wrist with a rubber band to stop smoking. We don't do that anymore, by the way, but I'm just giving a visual example. That takes time. And so the evidence gathering is a little harder. And you have to dig a little more to get it. And insurance doesn't like it because it means they have to reimburse longer than like just those 8 sessions, depending on some sort of insurance. So evidence-based, I actually went to a talk at APA this summer when I went to the convention that someone at a very reputable university, was a younger guy, less than 30, was bashing the whole idea of evidence-based, which was awesome. That's why I went. The title had it in there. What he was saying is we've gone too far. It's not that we don't want evidence-based for what we're doing. We should, because there was a point in time in our field that evidence-based was sorely lacking. We're like, are you really helping these people, or are you just taking their money? We want to have like the basic tenets there, and then we can see the change over time, and clients can actually say, yes, I feel like I'm less depressed, or I do feel like I'm learning who I really am rather than masking, right? Those kinds of things are a little more long-term to measure, and we can't dump those by the wayside because we want this easily measurable CBT thing. That's sort of what he was saying. So it sort of swings back. But you'll get that a lot. You hear this word evidence-based. I teach at a university where we're training psychologists, right? So it's all about evidence-based. But even for us, because we're a social justice institution, almost everybody who teaches there has some psychodynamic training and really teaches in that regard. It's about relationally being with your clients. So we do a lot to give the evidence base of that. When we really started pushing through the idea of multiculturalism with students beyond just these are different cultures to what is oppression, what is being the agent of oppression, and what is being the target of oppression, and really having our students confront their internalized racism, ableism, whatever. Those are hard things to do. We didn't just do that willy-nilly because we thought it was a good idea. We looked at the evidence base behind it and why we needed to do that and how that makes them better clinicians, right? So the evidence is usually there. It's always there in our field. It's just you have to do a little more research to find it. But you'll get this icky ABA therapy, the bad ABA therapy. By the way, like you said, insurance reimburses it. It's evidence-based short term. I can condition a child to stop hand flapping, just like I can condition a dog to stop barking. All you're doing is getting rid of the behavior, extinguishing the behavior. It has nothing to do with what's fueling it, what is the need for it, is it serving a purpose? No, just get rid of that one behavior that I've deemed bad. And that's totally evidence-based. So you have to kind of look at the whole picture of what exactly is going on here. And we've talked about this ad nauseum in the podcast, right? Now you've taken away kids' basic regulating behavior, and now you're wondering why they're running up and down the walls because they can't bounce their foot up and down anymore. They can't hand flap. Yeah. So evidence-based needs to be taken with a grain of salt in terms of you can't have this myopic view and only focus in on this one little thing. You have to look at it in terms of the entire picture. So that's why we're like, oh God, let's talk about evidence-based. It's a heavy thing, right?
It's a thing. And I think really quick, hey Dana, move your, you've got a microphone rubbing against your shirt.
Sorry.
Sorry, audience. I didn't want to interrupt Dana's flow.
I think I may be on the wrong microphone. Is probably what
if you want to switch that. We're just a little
talking.
This break was brought to you by Dana's.
Can you hear me now?
That's so much better.
I'm on the wrong microphone. I apologize. Yeah.
Okay. Gosh, I mean, I think if we think about the importance or why we're at this place. Mm-hmm. as a field, as a field of psychology, it's because we've come from this place of not being the scientific discipline, right? Yeah. So we're the touchy-feely, right? We're the touchy-feely pseudoscience discipline, and so like in PT, your rehabilitation exercises worked because you got, 4 or 5 degrees of motion more than if you had right? Like that's very measurable. It's objectively, tangibly measurable. You know that you cured cancer because the cells no longer have cancerous,
Yeah,
any
exactly.
markers,
The tumor
right?
shrunk. Okay, well, look
Right.
at that.
We
Yeah.
know these things, but for human behavior, where
Mhm.
we are all products of our cumulative experiences from our lens.
Yeah.
We're all very different in the way in which we relate to ourselves in the world, right?
Mhm. Mhm.
And so one, I think there's been a chip on our shoulder as a field to be like, no, we're
Yeah,
scientific. We can
exactly.
prove that we're doing whatever. And the other is that when we try to make all behavior object
Yeah, like measurable,
objective,
easily measurable. Yeah, yeah,
we actually don't then, I think, capture the nuances of who we are, why we are.
yeah.
And that's why
Objective means I can see it as the other person. Now
right,
I'm away from the inner world of that other person. So now I've got
which
to
is where
deal
most
with
of the
it.
stuff
Yeah,
is happening.
yeah, exactly.
The private world is where most of the stuff is jamming. Like,
Yeah,
right? And
yeah,
so, how often do our objective, tangible, visible behaviors, how often are they not a reflection of how we're feeling inside? I mean, I think about masking, I think about impression
yep,
management.
yep, yep.
And sometimes obviously it bleeds over because, we're dysregulated and
Yeah,
it's clear that we're dysregulated. And that's a duh. Like, that's a duh
yeah,
statement.
yeah, yeah, yeah.
But, short of like, this is what's normal. If you
Hmm.
behave in these ways, then you're fine. Like, what defines a well-being? What defines less depression? What
Yeah.
defines less anxiety? I mean, those are all very personal things. And so I do feel like we do get caught up in evidence-based, and then it takes forever. For those of you that don't know how long research takes, you
Hmm.
go through a crazy process of IRB, which is basically the ethical board in an
Yeah.
institution to say what you want to do is ethical. That
Yep.
takes forever.
And
Then
what
it's
you're
got to
doing to
like,
make sure you don't hurt people and what risks, how are you minimizing risk? Yeah.
right, all of that stuff. And then it takes forever to do the research and then write the research. And then it's got to go through peer review in order to be accepted into a journal. I mean, by the time it gets into the journal, we are so beyond the idea of what you just,
It's 3 to 5 years in the
yeah,
making, which is
yeah.
so it's lagging behind. Yeah. Yeah. That's
Yeah,
right.
which is and that's why we've always said, the research is very siloed. It
Hmm.
doesn't get to the clinicians, to the people that have our feet on the ground and are
So
actually,
yeah,
supporting
yeah.
people.
And you're talking about sort of our history and feeling like we were, you're not real because you don't have evidence base, and absolutely that being the origin. And then we also, you think about research, think about like rats in a cage and that kind of stuff. And in psychological research, there's what we call quantitative research, which is the kind that you get like these discrete variables that you can put into SPSS on a spreadsheet and you can find significance rates and all this kind of stuff, which is the evidence base. And then there's qualitative, which actually is proven to be as rigorous in terms of the findings, but maybe not as what we call generalizable. That I think is actually more useful in our field. I just submitted to IRB. I have requested on my TikTok videos, they can download all the comments that I've gotten in the videos, completely sanitized. Even though people don't use their real names and their user handles, they take all the names off. It's just going to get this giant spreadsheet of comments. And so what I'm going to do is go in there and do a process, what's called a qualitative process, just to find themes in those. And for me, I want to look at like capturing the adult autism, ADHD, neurodivergent experience just in general in that way. And that's going to be super useful because I'm going right to the source. I'm going right to like these organically driven comments. I'm not having
Mhm.
you fill out a questionnaire that I've already decided what you're going to see in the questionnaire. I've decided which questions I'm going to ask, and there's no room for anything outside of that. That's what quantitative research does. And so it has limitations in that regard. And then qualitative has limitations in that it's usually done with less people, but it's also the way we identify variables that haven't been identified before. We want to get a handle on them. And then it kind of goes into quantitative realm and they kind of go back and forth. But there's been like this snobbery against qualitative research too, which actually, with the pieces that you're talking about that are most important, that's how we get at those. tell me what your experience is in therapy. Tell me what your experience was when you found out you were neurodivergent. Tell me what's going on inside. And I'm not going to give you a questionnaire to have you check off what you identify with. I'm just going to have you tell me what it's about. That's qualitative research. It's evidence-based, but it gets kind of poo-pooed by peer-reviewed journals still. Yeah.
And who, I guess for me, and again, like I get it, right? I get the system, right? Mm-hmm. The system is not going to pay for treatments that are not evidence-based. Okay. I get it. I mean, I get it on the surface, on the face of it. I understand. However, what is effective treatment for a person? And I think, this is something that I work with my clients, which is, how are you feeling today?
Yeah.
Yeah.
Yep.
Talk to me about that. Like, and so often the progress or the movement or the progression comes from these little things that are happening kind of all over the place. And so how often do I get, oh my goodness, from a parent, let's say, who's saying, oh my goodness, my adult child now is able to make their own appointments, drive themselves to these places, right? Meet up with a friend that they want to.
Yeah.
Still needs a lot of rest and recovery, but there's more agency and a felt sense of control in their life, which then feeds other things. That to me is evidence.
Yeah. Oh yeah.
But right? That's not necessarily going to be enough evidence for an insurance company. But I do think this is also where ABA's effectiveness has been overestimated. And it's because we're working with compliance-based behavior. And so we're really just looking at conditioning, not the meaning of the behavior, not the meaningfulness of the skill. Right. And so it's much easier to do that than to measure relationship, right? The quality of a relationship.
Yeah, and conditioning for the listeners is really just about teaching a single behavior, like Pavlov got the dogs to drool at a bell.
Right. It's based on reinforcement and punishment. I mean, in a very reductionistic kind of way, right?
Yeah. I can remember this one when I was still vet teching. It was while I was in psych school already, but I still remember this woman saying, "My dog's not behaving," and I said, "What do you mean?" She said, "Well, we taught him to sit when we want him to be quiet, and now all of a sudden he isn't listening to us." And it was all this: he's not listening, he's being, blah blah blah. And I said, okay, so he's 12. It was a little bit older for a dog. It turned out the dog was arthritic and sitting down hurt. So we could look at that and say, all this meaning that this person put to, they're being sassy, they're not listening anymore, when actually it was about pain, that sitting down actually hurt. And then actually a conditioning comes into play there that they weren't identifying, which is pain gets avoided, so the dog stops sitting down. So that we could say that's conditioning too. To speak to your point, it doesn't tell you anything about the larger context of what's going on, and that's harder to view and look at. And once we figured that out, the dog had really bad hip arthritis. The owner felt terrible. I said, well, don't feel terrible. You didn't know, but it's a really good lesson of not assuming until you know what else might be going on, particularly if it's a big change to behavior, right?
Yeah, and that when we see things through the eyes of compliance, I mean, that's a good example of seeing behavior through compliance, through the compliance lens. We then only say that that's a willful disobedience of X versus how to understand this.
Do what we asked it to do. Yeah.
Going back to the dog training, Dana, something that I found to be really interesting in training all my dogs is that not all dogs want to lay down on command.
Yeah. Yeah.
Right. And there's a lot of reasons for that. And one of the biggest reasons for a dog not wanting to lay down is really about safety and trust.
Or breed. They're not supposed to be
on the
they can crouch down, but they, like a border collie, needs to be ready. They will rarely want to lay down where they can't get up as fast as possible.
Right. Yeah. Right. And so, you see this in like these kind of obedience-based classes. Yeah. And I'm like, one, that dog is so anxious. Forcing them to lay down is going to be very unsuccessful because they're not in a state of mind to be able to do that. And I just feel like, okay, so then, a good dog instructor or trainer, like they educate people about this. And then people get it. They're like, oh, okay, like, oh, that's how dogs are. And I'm like, but we don't
Not every
necessarily
dog.
extend this to humans too. Like,
Good point. Good point. Yeah, why not? Well, I don't want to pay it. Insurance doesn't want to pay for it. Yeah.
well, and I like, and you and I spoke about this off record, right? Off the air, which is there are so many families that understand that ABA may not be, especially depending on the ABA provider, may not be the best treatment or intervention right now because of the backlash it's getting for good reason.
Yeah.
But it's the only thing that their insurance will provide. And this is a family that doesn't have a lot of means, might be a single parent. We know that divorce is very high.
Yep.
Very, very high in the autistic population, parents, in the families. And what are these parents supposed to do?
Right. Yeah. Exactly.
I mean, this is the thing. This is that, and that's just a real life situation. Parents will be like, is there any way I can work with an ABA provider to move away from compliance-based training, to move towards person-centered treatment? Yeah. And there are many ABA providers who are more progressive and are really starting to think about these things.
But you have to identify them first. You have to find.
You got to vet them.
It's hard to do. Yeah.
But if that's your only intervention and support that you get as a family that is being provided, what do you do?
Yeah. Yeah. I think, a lot of people can relate with this idea of when iPads or keyboards first came out, and lo and behold, you have these disabled folks who were non-speaking speaking. And they were, it's like, well, what did you expect? You weren't giving them the means to communicate, because if they're non-speaking, they can't communicate by speaking.
Yeah.
Right.
Yeah.
So it's that same sort of thing. How do you bring in a measurement tool that works for the person you're measuring? And evidence-based as it isn't about the person you're measuring, it's about the researcher. And that's already, a bunch of degrees of separation, and that's inherently problematic.
Yeah. And there are underlying motivations of a researcher. We're not talking about doing double-blind types of studies here.
Right. Exactly.
We are researching, and there are things that exist for us, like confirmation bias. And, I'm going to find the things that support my thoughts and my theories.
Yeah.
And by the way, everyone, like, you can finagle statistics into your favor.
Oh, yeah, you can. Yeah.
We all know that.
My students.
Yeah. You can if you want something to be significant, you just need a lot of people.
Yep.
Anything will be significant with a lot of people.
Yeah. I know.
Which is why we're trained to look at effect sizes. But besides that, it's like, listen, we're not saying, I think for, Dana and I, we're not saying, oh, poo-poo, evidence-based, don't believe it,
Right.
Okay, fine. But we are saying is that not everything that's effective is clearly evidence-based.
Yeah,
and there are some evidence-based things that may not be for you.
Yeah, exactly. Just be educated about it, and don't take it as this panacea, but also don't dismiss it completely. Yeah.
Make an informed choice.
Yep.
Really think about the value and the opportunity costs and the fit for you and your family for these types of interventions. Think about it, do research on it, and then make a choice on whether that's right for you or not.
Exactly.
Don't just rely on a professional to tell you that's good or not. I mean, if you're going to a professional, and that's what they do, it's going to be effective. For them, according to them, it's going to be effective.
Right. Exactly. Yeah. It's sort of like going to have your house redesigned. I watch a lot of home improvement shows and redesign shows, and they don't get any input from the people living there. So they're just designing the house like they think it would be really nice. And then it's so funny when you see people walk in, they're like, oh yeah, this is really nice. And you're like, oh, they hate it. Versus the shows that you can tell they at least spent some time with the homeowner to find out what their style was and or at least what they like, even if they don't know, I don't know what my style is. well, do you like natural things? Do you like, modern cutting edges? And, so it's sort of that same thing. You need to get in that pond to know the pond. You can't just look at it from far away and say, oh, that's the pond. Right.
Well, because I think the pond's pretty. Or like,
Yeah.
I think the pond's pretty, so therefore you must think the pond's pretty.
Yeah.
Or
I saw a
nice.
Monet painting of a pond once, so now I know ponds.
Yeah. Oh my gosh, when you're talking about someone coming in to redo your house without your input,
Oh my God,
that seems like a nightmare for me. And I do a lot of cooking. So one of the first things I would do is I would bring my counter height just a little lower because I'm super short.
Oh yeah.
And that would be really helpful to me. But guaranteed, if I had a designer that didn't consider that, my counters would be far too high.
Yeah. And I see the good ones do that. They're like, oh, like really tall people need them higher, or people that are not as tall want them lower. Yeah, totally.
Right. Yeah. Thank you for that very politically correct description of short people. Thanks, Dana. I read right through that.
Yeah, I'm pretty versed at that. My wife's 5'2", so I'm very practiced on trying not to do a value judgment on height. Having grown up at a time when short people have no reason to live was a verse in a song. Just for those of you that are younger. Top 10 hit.
Top chart. It was on the top of the charts.
Exactly. But yeah, it has to be evidence-based is a good thing, but you also have to not do it at the cost of the context and not seeing the forest for the trees. And that's sort of the point we're trying to get across.
Yeah, evidence-based is one factor, one variable in a decision.
Yeah, exactly.
Don't make it the only variable.
That's exactly right. Yeah.
Gosh, we're good.
We're good. Yeah.
Yeah.
I love it. Now we sound like the people on The Delicious Dish on SNL.
Oh yeah, let's bring it.
It's so good.
We're very good.
It's very good. It's very good.
Excellent. Okay.
Really, really well. I love it.
Oh my gosh. Marvels, we love you. Thank you so much for being here. Thank you for just playing in this sandbox, really, for being a part of a community that where we can have these kinds of conversations. That's a positive, productive place that uplifts and empowers people. I think we don't have enough of that out there. So thank you for being here, and your comments are awesome. Dana and I love reading them. Yeah. They're incredible. So keep it up. I mean, I think as we said in the last episode, Dana and I are thinking about making some really dorky merch. Yeah. So if you think that's a good idea, let us know. Yeah. Maybe we'll pick a common commenter and maybe send you a hoodie or something.
Yeah, yes, I'm a dork. I'm a proud dork, or because someone said, yes, I'm a dork, and that's a good thing. We can do stuff like that. It'd be great.
Yeah, we can just vote on different sayings for sweatshirts. Oh my God, it'd be so funny.
That'd be a blast.
Awesome, everyone. All right, have a good one. We will see you in the next episode. Bye.
Bye, everybody.